Dr. Mackillop is a fellow of both the Royal College of Physicians and obstetricians and gynecologists, and she's a consultant obstetric physician from Oxford. So thank you very much for coming.
Lovely, thank you very much for inviting me today. So my remit is to talk about diabetes in pregnancy and the challenges as I see it as a practicing clinician in this area. I was asked to present is that working? There we go. A declaration of interest slide. The things in grey probably, hopefully, mean that I actually should be giving this talk, and it qualifies me for the talk. And then I've got two declarations at the bottom there that are pertinent to the audience and also to this talk. But actually, I won't be talking very much about it at all today, those two things. So I'm going to start by talking a little bit about the prevalence of hyperglycemia in pregnancy. This is data from the International Diabetes Federation from 2020, published in 2021, and shows the prevalence of hyperglycemia from all sorts is around 1 in 6 live births worldwide, which equates to around 21 million women per year. And that prevalence is increasing, and it's probably increasing for 3 main reasons. Firstly, the background demographic change and, of course, the obesity epidemic that is affecting us worldwide. But also there are other changes, particularly in screening. So we are screening more women, and there are now countries that do universal screening for gestational diabetes, which is the most common form of hyperglycemia in pregnancy. And also the lowering of diagnostic thresholds has meant that more people then are diagnosed with hyperglycemia in pregnancy. And you can see here there's very profound differences. So the UK and US, the IDF say 20% of pregnant women will have hyperglycemia. In Spain, it's up to 30%, but that they have universal screening. So it does make a massive difference to whether you have targeted screening, as we do in the UK through NICE guidelines, or whether we have universal screening. And that obviously changes the prevalence quite dramatically. So as to the types of diabetes in pregnancy, gestational diabetes, by far the most common. Around 85% of all diabetes in pregnancy is gestational diabetes. The true incidence in this country is unknown, actually. At the moment, our data capture through the maternity data set is not good, so we don't know how many people, but it's probably more than 100,000 women per year in the UK. It's important because the chances of transitioning to type 2 diabetes in 10 years is high in these women, and therefore we need to know about them. Type 1 diabetes is obviously there as one of the types of diabetes affecting pregnancy, and there's been a dramatic rise in women with type 2 diabetes over the last 20 years. So this is National Pregnancy and Diabetes Audit. So this is data from all maternity units in England, 172 maternity units in England, and it is an audit that is mandatory, so that the uptake is excellent and the data capture is excellent. And what we've seen between 2014 and 2020 is that type 2 diabetes is now the most common form of diabetes, pre-existing diabetes in pregnancy. And that is a big change from when it was only a quarter back in 2020. So you can see that as we've seen in the demographic changes, an increase in type 2 diabetes for everybody else, that's true in the pregnancy population as well. And then MODY, maturity onset diabetes of the young, we do see it. We see it in our clinics, often because we think about it, because if someone with no risk factors who's slim presents with hyperglycemia, we think, oh, could this be a monogenic form of diabetes? And it's also very interesting, the interplay, because depending on whether the fetus has also inherited that monogenic diabetes will change our management in pregnancy. So we have to know about the mother and the fetus in order to give the appropriate management plan for that woman. A little bit about glucose regulation in pregnancy. So pregnancy is an insulin-resistant state, and it favours transfer of nutrients to the baby. And that's probably an evolutionary thing. It makes sense that when we were running around as cave men and women, we didn't know where the next meal was coming from, that our bodies adapted to nourish the child such that when it was born, it was more likely to survive, and therefore, of course, our family and generation was more likely to survive. But obviously nowadays, with our sedentary behaviour, increasing obesity and Western diet, and the increase in type 2 diabetes, those glucose regulatory sort of pathways, if you like, are overwhelmed, and this leads to gestational diabetes. And just to sort of orientate you, the maternal pancreas needs to increase the insulin secretion by around 250% in order just to cope with that insulin resistance. So it is a massive change that is required in pregnancy, and that is where women at risk of this manifest with clinical disease. So what are the effects for diabetes in pregnancy? Well, there's a number of effects shown here. Clearly things like miscarriage and congenital malformations are primarily in women with pre-existing diabetes rather than gestational diabetes. But then hypoglycemia from any cause can increase the chances of pyelonephritis, gestational hypertension, preeclampsia, preterm delivery, perineal trauma, and macrosomia, for example. And you can see here the stillbirth rates. This is from Helen Murphy's review in The Lancet recently. Stillbirth rates for women with type 1 diabetes is 10 per 100,000, 10 per 1,000 births, and compared to the ONS statistics, which is 3.8 per 1,000 births in the UK in 2020. So a threefold increase for type 1 diabetes, but an even higher increase, so 2.7 is the background risk of stillbirth, and if you have type 2 diabetes, your risk is 13.5 per 1,000 births. So a big difference in the stillbirth rate in women with diabetes. Hypoglycemia is more common, and that's because often we're striving for very tight control to try and improve the metabolic milieu in the baby, and obviously that can lead to profound hypoglycemia, which can be life-threatening in itself. Diabetic ketoacidosis is detrimental to the fetus, and caesarean section is much more common in women with diabetes. On the neonatal side, NICU admission, there are varying studies, but generally NICU admission, to neonatal intensive care unit admission for the neonates is much higher, and a plethora of neonatal morbidities. Again, neonatal death is higher. And then importantly, we know that women, so babies born of women with hypoglycemia are more likely to have excess child adiposity or higher indexes of child adiposity, and also be at higher increased risk of cardiovascular disease and type 2 diabetes in later life. So there is a generational effect, and that's really where the interventions come in, and that's why we strive for good glycemic control, to try and prevent this intergenerational effect. So the challenges. I've put here 4 challenges. The first is about definitions and diagnosis of gestational diabetes. And although you might think that's not necessarily pertinent to primary care, because of this intergenerational effect, I think it actually is, and I'll try and convince you of that. I then want to talk a little bit about pre-pregnancy preparation for women with pre-existing diabetes, effective management strategies during pregnancy, and particularly to prevent gestational diabetes, which is what we should be striving to do, and then, of course, postnatal care as well. So challenges for definitions and diagnosis. I want to give you sort of a bit of a historical context really to this. So the gestational diabetes as a phrase was probably coined in the sort of 1950s. And then by the 70s, there was an understanding that it was, or definition, that it was carbohydrate intolerance of varying severity with onset or first recognition in pregnancy. So quite a broad diagnosis, and obviously included those people that hadn't been diagnosed with pre-existing diabetes before. That has evolved to a bit of a tighter diagnosis definition recently, so hyperglycemia that is first diagnosed during pregnancy with glucose levels that are below what is considered diagnostic for diabetes, and I'll come on to that, and then it resolves post-birth. So that is a tighter definition. And as I said, why is it important? Well, as I've said, it is common, and it's now the most common medical complication of pregnancy. It is more common than hypertension. It does identify a group of women at high risk of pregnancy and neonatal complications, as I've just talked about, and it does identify a group of women and infants at high risk of long-term cardiometabolic disease. So that's its importance. And the rationale for treating is really quite new, really. I mean, when I started as a consultant, we still weren't screening everybody in a sort of standardised fashion, and it wasn't really until 2008 NICE guidelines came out that there was a sort of screening strategy for gestational diabetes. And that was as a result of these 2 seminal papers. So in 2005, an Australian group, Crowther's group, published this RCT just around 500 women who were diagnosed with gestational diabetes based on a 75-gram oral glucose tolerance test, and they were randomized to either management, which was diet, blood glucose monitoring and insulin if necessary, or routine care, which was effectively just routine antenatal care and lifestyle advice. And what they showed was that there was a reduction in serious perinatal complications in the intervention group, although overall all of the complications were low in terms of absolute numbers, and the number needed to treat to prevent a serious perinatal complication was only 43. So that gave us really an understanding that actually we should be picking up these women and then potentially treating them. And then the second paper that came out was an American paper, Landon, a couple of years later, a similar-sized randomized control trial. This time, they used much more tighter control for a tighter, they were sort of milder gestational diabetes. So the women who were randomized had an abnormal 100-gram glucose tolerance test, but their fasting blood glucose were only less than 5.3 or lower. So these were mild group. Anybody more than that weren't randomized to this trial because they were actually treated. So this was the mild end of the spectrum, and it didn't show any significant difference in the composite outcome, but it did show in all the secondary outcomes a significant difference in the intervention group and a reduction in hypertensive diseases. So even in the mild gestational diabetes, it appeared that it was of benefit. So what happened next? Well, HAPO happened next, and this was published around about the same time, and this was a large multi-center study, and it was performed in order to find the thresholds based on neonatal and obstetric outcomes. And they had over 23,000 women in their study. And the take-home message from it was that there is a linear association between glucose and outcomes. There was no inflection point. So we couldn't say, well, once their blood glucoses were reliably over 7 or fasting or something, that's when we had to intervene. It was linear. So they took the approach that they were going to use 1.75 standard deviations above the median for adverse pregnancy outcome as the threshold by which that you were going to diagnose a woman. And what that meant was the fasting blood glucose of greater than 5.1, a 1 hour of 10, and a 2 hour of 8.5 after a 75-gram load of glucose. Which sounds evidence-based, it sounds sensible, it's based on outcomes, it all sounds a really good idea. The other thing they did was just identify what overt versus true GDM was. And so these are thresholds for what is actually someone who's got underlying diabetes, it just hadn't been picked up yet, versus those people who've got this sort of hypoglycemia that goes away. So it sounded like a good idea, and it was pushed internationally a lot and adopted by lots of very important people like the WHO, FIGO, the American Diabetes Association. But what they didn't do was a cost impact analysis straight away, and what it transpired was hundreds of thousands of women were being diagnosed with diabetes in pregnancy, and that had huge cost implications. And the other concern was that there was a lack of data regarding using those thresholds and whether we were going to actually improve outcomes using those thresholds. So they advocated it before there was that clinical information on outcomes. So it wasn't, it was adopted by a lot, but it wasn't adopted by some countries, including our own, and NICE decided to do something different. So NICE looked at decisions based on economic modelling and cost effectiveness, and came out with a different threshold for diagnosis. And again, there was quite a lot of reticence within the diabetes community because, again, the thresholds had not been tested clinically. There were some things that they didn't include, including large for gestational age and macrosomia. And there was a sort of a push, really, that we should be looking at modelling costs on stratifying treatment rather than changing the diagnostic criteria. But it was pushed through again, and it's interesting that, over 10 years later, nearly 14 years later, although there's been a number of observational studies exploring the differences between these two diagnostic approaches, there's been no large RCT comparing the two properly. And that has led to variance of use of these two diagnostic criteria. And this is just a communication from a group that I'm involved in pre-COVID, and they showed that actually in the UK now, 80% of maternity units use the NICE cutoffs, and 10% use the IAD PSG cutoffs, and 10% do their own thing. So it's just not standardised, and I think that is a problem. And it's a problem because the disagreement of screening policies, diagnostic thresholds and target thresholds means that there is confusion and mixed messaging amongst women. And I've had a number of women who've come to my clinic and they started off their care down the road in a different hospital, and they come to my clinic and we do something completely different. And maybe they wouldn't even been diagnosed if they'd been in our hospital from the beginning. So it is a confusing time for them. I think there is a potential that we're over-treating some women and not picking up others, because we're just, we're picking up a cohort. I haven't even mentioned the fact that, obviously the glucose tolerance test may perform very differently in a 120 kilo Caucasian woman than a 50 kilo Southeast Asian woman, and all the complexities that come with that. So, and I think it does stifle, studies and research, because we can't really lump all these people together when they've been diagnosed with different criteria, and it does stifle also multi-centre interventional studies, because we're all just using different criteria. So it's not ideal, and again, although it maybe it's not particularly pertinent to your day-to-day clinical practice, I think it's really important to understand that, because it has knock-on effects for these women and how we manage them in later life. So the challenge too for us really is about pre-pregnancy preparation, and a lot of this data comes from the National Pregnancy in Diabetes Audit. And this was data taken from the last publication, which was published last year for the year before 2020. And so the first thing today is to say about congenital abnormalities and perinatal death are lowest in women with very good HbA1cs at conception, which makes sense. So an HbA1c of less than or equal 48, which in old money is 6.5. And you can see here, this is congenital abnormalities. They increase. Blue is type 1 diabetes. Grey is type 2 diabetes, and this is the percentage of congenital abnormalities starts to increase after that point and goes up to just above 10% for women with type 1 diabetes who have an HbA1c over 86 millimoles, which is equivalent to around 10%. And likewise, serious adverse perinatal outcome, which is perinatal death, stillbirth, or major congenital abnormalities, has the same thing. So it starts off here about the same, and then increases up to 14% in women with type 1 diabetes. So it's a major issue. And really, also sadly, there's been no improvement over the last 7 years, with 7 out of 8 women in the audit still being not prepared for pregnancy, and I'll go on to what I mean by that. And this is lowest in women who are from the most deprived communities, so talking about equity of care, this is definitely an area where we need to work on. So in these communities, only 6% of women with type 2 diabetes are prepared for pregnancy, and only 21% of those with type 1. The other disappointing fact is that there's no overall improvement between pregnancies. So you would imagine if a woman has had a pregnancy, she's gone through all of this stuff, she knows all about it now, she knows about 5 milligrams of folic acid, etc., etc. The audit data does not suggest that she's in any way better off after the next pregnancy. There is some indication that women with type 2 diabetes are more likely to be on 5 milligrams of folic acid, but unfortunately their glycemic control is also likely to be worse in the second pregnancy, often because of probably pregnancy and inter-pregnancy weight gain. So when I talk about preparedness, there's 3 really metrics that they use. One is about how good the glycemic control is at conception. One is about the percentage of women who are on medications that have potentially fetotoxic or embryotoxic effects. And one is about the use of 5 milligrams of folic acid as opposed to the normal 400 micrograms. And you can see here, this is data over these year points. This is again type 2, type 1, that percentages are really low for good glycemic control, under 20% for those women with type 1 diabetes, and only reaching 40% in those with type 2 diabetes. These medications, so ACE inhibitors, statins, things like that, again, there is still a high proportion of those women with type 2 diabetes that are on these medications, more than 10%, and that hasn't changed. And the 5 milligrams of folic acid, yes, there are higher, but we're still not on over even the 50% mark, and particularly with those with type 2 diabetes. they're much less likely to be on 5 milligrams of folic acid. So it's a little bit depressing. It's one of the things I think we need to sort out. And so that is one of the challenges I'd like to talk about today, really. So in summary for Challenge 2, NPID does recommend dedicated pre-pregnancy coordinators to focus on enhanced provision of contraception and also support of pregnancy preparation. And of course, that requires commissioning and all sorts of things. And it sounds great, but how do we actually deliver that? Practically, what do we want? These women need to be on 5 milligrams of folic acid. They need to have really good glycemic control going into pregnancy at the point of conception. They need to not be on any other oral hypoglycemics other than metformin, which is used in pregnancy. And they need to have also stopped their fetotoxic or embryotoxic drugs prior to conception, ideally. So that's Challenge 2. So Challenge 3 is about effective management strategies. And really the management strategy for hypoglycemia in pregnancy is monitoring of blood glucose and obviously tight control, lifestyle interventions, making sure you don't have excessive gestational weight gain and physical activity, and of course pharmacological treatments, which really is metformin, which is not licensed for use in pregnancy, but we use it a lot in pregnancy. It does cross the placenta. There are some concerns about in normal weight or low weight women, it might increase the chances of a smaller baby, but insulin doesn't cross the placenta and is completely safe. They're both safe. We use them both, but we don't use any of the other oral hypoglycemics. We know, again, from NPID that in type 1 and type 2 diabetes, perinatal death, preterm birth, large for gestational age, and neonatal intensive care is lowest in women with good glycemic control in the third trimester of pregnancy. This study, and Helen Murphy's group, was a fantastic multi-centre trial, international trial, looking at continuous glucose monitoring in women with type 1 diabetes only in pregnancy. And that was published last year and showed that there was a benefit for women with type 1 diabetes to have continuous glucose monitoring during pregnancy. Particularly, it reduced the risk of neonatal intensive care or the time at which they needed to be in intensive care. And that has led to NHS England prioritising this for use, and it is being rolled out through the UK. And there is now discussions about whether we should be offering continuous glucose monitoring to women with type 2 diabetes, because as I've shown you, their outcomes are certainly not any better and maybe even poorer than those with type 1 diabetes, but for potentially not different reasons, not always because of hypoglycemia. So in terms of gestational diabetes, interventions to prevent gestational diabetes have been modest, really, I would say. And these were two studies that were done, Upbeat and Limit, at very similar times, and looked at dietary intervention. And unfortunately didn't show that with dietary intervention there was a reduction in the prevalence of gestational diabetes, or that there was a reduction in gestational weight gain. But it is, again, a bit frustrating because we have women that we now, we look at their risk factors in early pregnancy. We then have almost, 5 months really before they're going to have a glucose tolerance test at 24 to 28 weeks. Is there not something that we can do in that time to try and mitigate that risk? But the answer is we haven't found a magic bullet yet. So it would appear from the studies that a combination of dietary and physical activity may make a bit of a difference, but not in the hard outcomes like stillbirth and perinatal death that really matter to women and matter to us. It's more around reducing gestational weight gain and caesarean section. So again, we've got to understand the patient population better, I think, and back to the conversations about personalised medicine and understanding the probably different phenotypes of women with gestational diabetes that have all been lumped together because they've all been given one test and they've all been given one threshold for diagnosis, and to then look at those women in the light of that and find interventions that are pertinent for individual groups or phenotypes within that big heterogeneous group that we're currently identified as at risk. This is just Cochrane data, Cochrane review data on physical activity, which essentially shows the same thing. We can reduce blood glucose using physical activity during pregnancy, but it doesn't really benefit hard clinical outcomes that are important. So the conclusions for Challenge 3, I think there are probably multiple phenotypes within this big group of women diagnosed with gestational diabetes, and that is within, using one diagnostic criteria. I think and it's exaggerated when you use multiple diagnostic criteria quite clearly. And what we do need is big data analytics to characterise those phenotypes, risk stratify them, and then identify personal interventions to suit each phenotype. And I think that's certainly an academic interest of mine and something that we need to work towards. And I think we also need to think about how we're going to develop those interventions that are going to be able to be delivered at scale, because many of the intervention trials to date are, women turning up once a week, taking 2 hours out of their busy lives in order to sit there and learn about carbohydrates or do physical activity. And actually what we need to do is understand what interventions are actually capable of being delivered clinically effectively and cost effectively at scale, and often that will be with the use of technology. So my final challenge is about postnatal care. Now, one of the things that I think we fall down on is this whole postnatal check. So a woman has a diagnosis of gestational diabetes, she leaves hospital, she's got a new baby, and she makes it to her 6-week check, but doesn't necessarily make it to having her blood glucose checked to see whether she's got underlying diabetes. And we've got a lot better, and the latest data would suggest that most women, even up to 80% of women, will have that postnatal check at some point. But the point is that we need to have that check annually thereafter because of that risk of type 2 diabetes. And very few women, probably 25% or less of women, will have that annual check. So we need to think about how we can do that. And the other thing that's reasonably new is that women with gestational diabetes are not eligible for the diabetes prevention programme. And there's no data yet to tell us whether that is happening, but communication with the NPID group suggests that it is very poorly taken up. And so we need to think how we can facilitate that in our primary care institutions. There are interventions that have been shown to stave off type 2 diabetes. Just the act of breastfeeding has evidence that 34% reduction in postpartum diabetes. Diet and exercise does help, and medication. There's a number of studies that use metformin in that postnatal period. But the follow-up is often short, and so we don't know whether it has a long-term effect on reducing the risk of type 2 diabetes. And of course, we have no idea whether it has a long-term effect on cardiovascular health, which is where we're trying to get to, obviously, with this. I've talked already about pregnancy preparedness and our lack of being good at doing it. And then I just want to finish really talking a little bit more about cardiovascular risk and surveillance, and sort of using this slide to really illustrate that. So just to orientate you, this is the y-axis is cardiometabolic risk, the x-axis is lifetime, and this is the sort of threshold for disease. So when someone actually manifests as having a problem. And we know that there are people, women, pregnant people, I think we call them now, that start with a low cardiometabolic risk, and they go through their lives and they don't have any problem, and it's not until really late elderly that they may have a problem, and let's call that type 2 diabetes at that stage in their life. And there are people who are born for whatever epigenetic reasons, lifestyle, environmental reasons, who start life at a higher cardiometabolic risk. You could say that that might be the infant of a mother born, an infant of a mother who had diabetes in her pregnancy may start off with a higher cardiometabolic risk. And when they get pregnant, they hit the threshold for disease, they become hypoglycemic and they have disease, and then it goes away again. Often it doesn't go right the way back down to how it was before, because they might have had a high weight gain. Certainly in hypertension, there is a disordered endothelium such that their probably hypertensive risk never goes back to normal again. And then they get pregnant again, and the same thing happens. So the chances of GDM in a subsequent pregnancy is very, very high. And then again, it doesn't go back again. And then they're on a trajectory to cardiometabolic disease much, much earlier than they otherwise would have been if they'd carried on this on this trajectory. And so we have this window of opportunity where we know the women who are going to run into trouble, and yet we're not really doing anything about it yet. We're not doing these interventions that I've just been talking about. We're not doing the postnatal interventions. And we really need to be, because this is data. This is not in a study. This is routinely collected data as part of routine clinical care that we should be utilising in order to benefit both the woman but also the next generation. So this is sort of a call to arms, I guess, in terms of the importance of gestational diabetes. So practically, challenge 4, it's really important to do a blood glucose check postnatally and yearly thereafter for reasons I've just talked about. It's important to offer lifestyle advice because that can affect the chances of diabetes in the early postnatal period, as can breastfeeding. The Diabetes Prevention Programme, please refer your women to that now because they are now eligible, and consider contraception and future pregnancy planning. Really at an early stage, even as that 6-week check, discuss it, because it's really, really important and we're not doing it well at the moment. So in conclusion, I think there's a lack of agreement for screening strategies and diagnostic thresholds for gestational diabetes, and that does impact on clinical care and stifles academic endeavour. We need to sort that out. I'm not sure how, but I do think that it needs to be sorted out. We need commissioning and other strategies to improve pregnancy preparedness for women with pre-existing diabetes, because we're not at the moment making any inroads, and there's been no change in the last 7 years. We do need high-grade evidence and large trials to develop clinically and cost-effective interventions to prevent gestational diabetes, because we do have a window in order to achieve that, but we need to work out how to do it. And postpartum follow-up after gestational diabetes is crucial to break the intergenerational cycle of cardiometabolic disease. Thank you very much.